Welcome to another episode of Let's Talk About Mental Health. I'm Nels and I'm an addiction psychiatrist working in Southern Vermont.
And my name is Robert Stack, and I'm a licensed alcohol and drug counselor, licensed mental health counselor. Good evening.
And as a reminder to our viewers, please send us your questions. We have a couple of ways to do this. The one is either texting or email, questions@letstalkvt.com, or through our Facebook at www.facebook.com/letstalkvt.
All righty. And, you know, I love to read, and I read a lot, and we got some information, so I wonder if we could start off just with this first article.
Yeah, there's some really important articles that
right.
People are bringing to our attention.
Right, and it was in the New York Times this last week, and it said there was a new approach advised to treat schizophrenia. And we have reached out to one of the people that they mentioned in here, Dr. Mary Olson, professor of psychiatry at University of Mass Medical School, and we're hoping to have her on as a guest. Yeah. And it's kind of interesting what they talk about, and is a combination of not meds, but other interventions. Yeah. The three things I think was interpersonal relationships, how to talk back to your voices, how to diffuse them, how to get something in there, and working with your family or working in a work environment, like people skills, if you will.
Yeah, which really makes sense. I mean, there's so many different spheres that are impacted with, anything we talk about, schizophrenia, addiction, depression, that to rely simply on a medication is very simplistic and absolutely not adequate. And I think that was something really important they talked about, is they were really using a broad range of approaches and treatments to really improve the quality of their life, as well as trying to diminish the voices and their impact.
Right, and one of the things that was clear, I hope it was clear in the article, at least when I read it, they were talking about your first episode. The test was done with people with their first episode. So we're talking about our teens, early 20s. And the difference was, they said, between the first outbreak or the symptoms, sometimes it's a year and a half before they get medical care. And one of the things they were saying in the study, if I read this right, is early intervention as soon as you can after the first break.
Yeah. And I think it's a little bit contrary, because to what's been done before. I mean, there's always been this understanding that the earlier you intervene, or the less relapses that you allow a person to have, that the better off they do overall, because we've thought that relapses of psychotic symptoms lead to a sort of overall decrease in functioning.
Right.
And so that was the idea, to start early. And a lot of the pharmaceutical companies have been pushing the idea of maybe identifying early warning symptoms and starting people on medications.
Even before,
say, they actually sort of have that first break.
But the other thing, and I'm sorry, go ahead.
Yeah, what I'm thinking now, now we're realizing that, through other studies that seem to support this one, that overuse of medication might not be the best approach.
Well, one of the things they were studying was dosage. And I think Robert Whitaker, when he was with us last year, he was talking about short term, yes, medications have an effect. Yes, and a higher dose, and they're very effective. But they found that, what was it last year? They had more frequent relapses?
Yeah, there was I think they mentioned it here, and also in a Dutch study by a guy named Wonderink, that if the people who took sort of low medication, or patients who avoided medications, had more lapses early on, and maybe in a year or two were not functioning as well, but when they continued on that path for 7 years, then you saw that group that took the low medication, no medication approach actually was functioning better as far as independence and their relationships and the impact, generally the impact of the illness.
Right. Now, I should mention that the following day, or maybe a second day after, 3 days after this was published, the Times published a correction. Saying that they had some information was wrong, and they pointed out a quote that they thought was not accurate. And so I just can't wait to hear more about this, and talk to people involved with this study and really find out exactly what they're looking at, what they're studying, what do they know so far. It sounds like, I think, you would hope the Times fact checker, they're going to put something on the front page, but it sounds like they were a little bit quick to make interpretation of the data that wasn't quite there. So I'm really hoping that we can have that Dr. Olson on with us, and love to hear more about it.
Because I think we're learning in so many places that are relying on some medications, like say opioids for pain treatment, and then the antipsychotics for mental health, for schizophrenia, that by not seeing as good function and actually seeing poorer function on the high doses and long-term medications, that it's costing our society more. We had initially thought that just prescribing medications was actually a much cheaper way to deal with these problems. Prescription, a pill, great, out and done, and now we're finding out that that's not really the best approach, and that we need to think about these as sort of a different way of doing this business.
Would I be in trouble if I said, is it possible we should think about that for opiate addiction?
There's been some talk about that.
We'll talk about that later. Okay.
Yeah.
Two other things I wanted to mention, and you'll have to forgive me, but I get the Vermont Digger every day on my computer, and it's like probably the best way to keep track of news in Vermont. And last week they had an article about a historian, Gary Shutok, who was given a talk about opiate use in Vermont. The present reflects the past. And there's going to be an article in this coming, I guess, American Historical Society. They put out a publication, I think. And basically it's just really interesting. And one of the things it says is that in 1852, Vermont outlawed alcohol.
Right.
And the sale of alcohol was outlawed in the state of Vermont because there was such a negative impact.
Right. People are drinking too much.
Yeah, right? Well, and it's a funny history of temperance movement, the women's right to vote. I hope it comes up in that movie about suffrage, the interconnection of their concern. But this article here, really, if you're interested, I know it's sort of trivia, but it really does talk about the history of opiates in Vermont. It does mention, about doctors getting trained and the mill diplomas, whatnot. And Vermonts Resistance in, what was it, 1910, 1915?
The Flexner report is around 1910, where they finally stopped and looked at basically the differences in supposed medical education and credentialing, and that was the beginning of our system now of having accreditation, common curriculum and testing for physicians in their training. Up until then, snake oil salesmen, fake doctors, bogus diplomas were quite an issue.
And it says here Vermont was reluctant to do anything about it, or was last or something. I don't know exactly how they phrased it, but we dragged our feet, I think it's
right. You can't tell a Vermonter what to do, right?
Yeah, and he talked about well, one other thing I want to mention is this author, because I've looked at his book. It's in the library here. He's a former assistant U.S. attorney for Vermont, and he's the author of a book called Insurrection, Corruption, and Murder in Early Vermont, Life on the Wild Northern Frontier. And that's really about smuggling during the early 1800s. Yeah. And so he was looking into this whole thing about opiates, and I hope he writes more about it, because I'd love to hear about the history. I would also like to hear about the whole abstinence movement in Vermont, because that must have been very interesting. Outlawing alcohol and the sale of alcohol. I never knew that.
The prohibition just didn't spring up out of nowhere.
Out of nowhere.
Right? So when it came, was in 1913, there'd been a lot of these movements and concerns building up for a long time. Right. They were about the moral aspects, about men neglecting their families, about productivity in the factories, and so it took a lot of time. And I think it's really great to put things in historical perspective, because like we said, opium has been around for thousands of years. I think you mentioned this article too, that even in the 1700s, before we were a state, that there was issues with opium and say liberal prescribing or sales of it. It was included in a lot of different sort of potions and notions that so in some ways what we think that we're going through right now is sort of special and new, and this terrible epidemic. There's something about it that's been present with us throughout history, which maybe can give us a different viewpoint on how we address this.
Well, it's interesting, because there used to be a big, strong argument that addiction in alcoholics was genetic. And one of my comments used to be that, well, there is no genetic history of all these opiate addicts who are now opiate addicts. Well, it may turn out that that's not true.
Well, we might have at least a couple hundred years of data here,
like this, previous historical genetic involvement. But that doesn't always make sense, because I know many immigrants that their second generation got into opiates, and there were no opiates where they Anyway, it's an interesting idea. If people are interested in it, and matter of fact, he would be someone that
would be fun having a historian on the show.
That's right, who really knew the history and not just me
not just looking at the last 10 years.
All right. Now, last but not least, and this is an article sent to us by one of our viewers. And by the way, if you have any of this stuff, I would love to hear it. So if there's people out there and they have these articles or ideas about addiction or mental illness or treatment, by all means, send it to us. I mean, send it to me. I read everything.
Absolutely. There's because so many times things are in the news and they have great value and they really point out some things we've been talking about. So I think.
But you're going to have to allow me to do. I just want to read this. I think it's just incredible. In the United States, we consume 57% of the world's opiates. And we're only 5% of the population.
Wow.
And the point of this article is that we should use less, so there's more for Africa, for undeveloped nations, like in competing for this substance, which is a commodity. We're sort of preoccupied. We're taking up a lot of space.
Right. So we're using morphine or hydrocodone for a headache or intestinal distress, which in a way means that maybe someone who's broken their leg in a poor area of Africa does not have access to opiates because the supply has all been siphoned over to us.
Now, people might have been making that we make too big a deal about big pharma, and that we're always, this diversion of drugs, and this is 2012, so it's a couple years old. So if anybody wants to disregard this, here's a good reason. It's 3 years old. But this is what they said: 259 million prescriptions for painkillers in 2012. The agency notes, this is the Centers for Disease Control and Prevention, CDC. The agency noted that there are enough prescriptions for painkillers for every American adult to have 75 pills of their own.
Wow.
Every adult. Now, the study also notes that 46 people die every day from an overdose on prescription painkillers. Now, this is in 2012. The article goes on to say that some of the drug companies have cooperated and made it harder for these painkillers to be used incorrectly.
Right,
there has been a crackdown. And then they go on to say a little bit further in the article, there's been a little bit over 20% reduction in deaths from painkillers.
Right, the prescriptions.
And then a sentence later, they say there's been a 23% increase in deaths from heroin. And one of the doctors in the next paragraph says something to the effect that perhaps there's a connection there. And that's what we've seen here. As people have shut down availability to prescription painkillers, at the same time we find more and more heroin coming. And that was true in Vermont. The first opiate abuse or widespread opiate abuse and dependency was with painkillers. And now I would say it's probably swung over to heroin. There was a time that most people's first heroin use was literally doing heroin. I mean, first opiate use was doing heroin. Mostly inner city, mostly ports, very specific areas in America. That's no longer true. For most of our opiate addicts today in Vermont, their introduction was with painkillers.
First with the pills,
And now in Vermont, there's more and more heroin. You can find heroin in every hamlet. That wasn't always true, but now it is. And I saw somebody got arrested with like 3,000 bags of heroin or 10,000. I don't know.
Like right outside a restaurant in Manchester. I think.
Huge number. I mean, at that point, that person is not friendly, and I mean, they're bringing misery to Vermont. I mean, this is not only are they making a lot of money, but they're making. I don't mind people making money, but they're making a lot of money on misery and pain. They're making a lot of money, and I know there's a movement among to not have convicts out of the state of Vermont and to bring them home so that they could be visited and everything. But I'm telling you, if you get caught selling 30,000 or 3,000 of heroin in Vermont, you should forfeit your right to even wake up in Vermont.
Yeah.
I mean, it's sort of, you know, that is just, you know, I'm not in for mandatory sentencing or anything like that, but boy, I tell you, when you realize how much harm it does.
And I mean, we put this out here. So again, we talk sort of the harms of commercialization. I mean, the pharmaceutical companies that made these opiates purposely misguided us. So I mean, of course, we always have the issue with, you know, troubles with addiction. That's always been around. And then, for example, like Purdue Pharma that made OxyContin said this is not addictive, and just kept on pushing and pushing and pushing. Great sales pitch to doctors, you know, swallowed it whole. And you know, what we now recognize are not really helpful prescribing patterns, and then we start to decrease that. So it's almost like a game of sort of whack-a-mole with, you know, the supply, right? So the pills go away, then heroin comes in, and it really kind of leaves us having to wonder about how do we diminish the demand, maybe? How do we do more rational prescribing, and how do we then, you know, work our way out of this problem, which has become pretty severe?
Yeah, my new copy of the New York Review of Books, the lead article on it is this whole idea of the purpose of life is to feel good, and how that was sold to us. This feeling good, or but because I want to mention this, and because it's part of the issue around the painkillers and whatnot. And you've heard me say this, and I've said it in shows before this. But part of the problem was when it was mandatory that people ask in a medical interview, do you have any pain? And then it had to become part of.
We were obliged to get to no pain. Right?
That's right. To acknowledge, and all we have is that scale 1 to 10. And you know, do you want help with it? What was the plan to treat it? And then within my own field of addiction, there came a study that was done, and my friend and colleague, Dr. Jeffrey Kane, he sort of suspects that this research wasn't very well done. But it came out and said not everybody exposed to opiates. Matter of fact, the majority of people who are given opiates do not develop problems. And it really made it sound like to protect one, we were making 20 other people suffer. And that's not really true.
Because and we know that this prescribing is not reasonable anymore, that people can live with pain. And I think when you look at how much the U.S. is consuming, it's like 50% of all opiates. I think like more than 90% of hydrocodone, worldwide supply. It has something to do with our demand for these substances and the commercialization and sort of our unsatiable desire for it make me feel good and let me be happy. That is really not good for the health of the individual or of the nation. So I think there's a real issue with this I need to be happy all the time idea, and you know, give me a pill to make that happen.
Now, last week I mentioned that you were working on an article around the legalization of marijuana here in the state of Vermont. And I know you have it coming up. It's getting ready to be published.
I think Friday or Saturday, the Bratterberry Prevention Coalition has a column, Matters of Substance. I
wonder if you could share a little bit about that.
Sure, no, absolutely. I called them up and let me hijack the column this week. So I've been getting increasingly concerned about this big, like, urgent push for us to legalize, for Vermont to legalize marijuana. The governor's in favor of it. I think we have Jeanette White, who's leading a lot of efforts in the Senate with the General Committee. And it just makes me, you know, worry, if this is a good idea to legalize it eventually, why the rush to do it now? And I think that there's a rashness to this and a lack of looking at the data that makes me feel there's a lot of sort of personal, personal experience, personal feelings in the legislature that is making this such a big issue.
Well, I think on one hand, you know, Vermont's known as a progressive state, but at the same time, it's a very conservative state. I mean, you know, you have to understand that it's a little bit of both, but the progressives, and I'm sorry to say this, is that it seems like it's progressive to be in favor of legalization of a drug, marijuana. And I think for a lot of people, they feel this is the time. I know they introduced decriminalization You know, they said, okay, let's decriminalize. Then it was sort of like, well, let's get medical marijuana because we have people. So for the decriminalization, they used the police department. I remember Governor Shulman standing up there with all policemen behind him, and we have people in jail, and we're going to, you know, and okay, fine, you know, let's decriminalize it. Okay, let's make it something. And then it was like, well, we need medical marijuana, and then we had people, you know, and you know, they need it because they have.
Yeah, when actually medical marijuana sort of precedes any kind of efforts around decriminalization.
Right. I'm sorry, I got it backwards. Yeah.
Which, as a physician and looking at how, to date, when you look at sort of people reviewing the validity of the studies and what kind of firm conclusions can be made about the medicinal value of marijuana, they're still not found anything that has adequate studying. The data is insufficient, or it's confusing, or just not very good. And so it's really kind of aggravating then that in a political process that the sort of liberalization of marijuana folks sort of steal the medical community to then say this is a medical sort of issue, we need to have this. I mean, this is not something that's being encouraged by any of the medical bodies.
No.
Medical marijuana is, while there are some doctors that sign on, the science isn't there.
Right.
It's just not.
It's interesting. And every other thing, when I was working around drug and alcohol prevention, I'm a licensed alcoholist. On the, you know, the favorite code word of the 90s and of this 21st century was evidence-based treatment.
Yeah.
So everything's evidence. You got to have good research. Got to prove that it works. Kind of like a movement away from AA and spirituality, which is all. It's very hard to get statistics on AA since
quackery
they don't
too.
do it. You know what I mean?
Been a problem.
But this is something that there's no evidence. There's very little evidence, and it's very anecdotal. And it's like, oh well, I mean, and that's not my big issue with this. But it's sort of, I think part of it is that they have a governor that they think will sign it, or at least let it become law. And they probably have the votes in the legislature, and I think they think now's the time to get this done. Yeah. They have Colorado, they have Washington, and there was a headline article in the paper about how much tax dollars we could get if we sell marijuana to everybody else in New England. I mean, literally, it literally said that in the article, like, this is how much we can say. I think the headline was $100 million can be.
So, and then too, and then there's a lot about, the RAND report is a very important document. The RAND Corporation put together a study for Vermont. And looking at just that factor, I mean, if you look at just the tax money, then that's fine if we get out there first and no other states follow us. If we look at what happened with lotteries, that's not very likely to happen. Other states might follow us, in which case then this like $10 million investment we have to make to line up legalization, that could be money wasted or lost if we aren't allowed to have sort of a monopoly around the New England area.
But do we really want to be the drug dealer for New England? I mean, you know, I mean, is that really our role? Is that, you know, like, well, come ski and get stoned?
Oh, yeah. Well, I'm not encouraging this, but I'm saying when you look at the tax revenues, they could be lost quite soon, and that weakens the argument that this is a big money maker. And if we look at alcohol, for example, we know that any kind of money that's brought in from taxes is dwarfed by far by the amount, by the cost of treating the disorders that come from alcohol. So we talk about a sort of big, you know, progressive sort of idea, and you know, I think that rather than looking strictly at like the tax money or looking at being perceived as liberal, then maybe a more progressive idea would be, you know, we're going to put the health of our citizens to be more important. We're going to put that before the possible commercialization of marijuana and the money that comes from that. And I think too that the legislature is not really appreciating the difference between decriminalization and legalization. Right. And if you look at, we have to extrapolate from so many other communities and studies that are not similar to ours. I mean, the Netherlands with decriminalization, Uruguay is now legalizing. They have very different systems that have more sort of socialized medical approach to it, and are you know, not, at least in the Netherlands, not legalizing per se. And we don't have systems like that. We've been against harm reduction in the U.S. We've been, you know, not looking at a broader sort of picture around healthcare around this.
It just, to me, and we were talking about this earlier, and You know, our local people who have worked so hard in prevention and trying in the high school, drug and alcohol prevention, you know, taking surveys, finding out what's available. We know that if you make it legal, it will be like gambling. And I've said this before. It's 30 years ago, if you want to play a number in Vermont, I don't know if you could find a bookie. The state made it legal. The state made gambling legal in Vermont. And now we see people, and you've seen them, I've seen them, sitting outside a store scratching those tickets and going through tickets after tickets. The tremendous amount of money that we make. We know that it's not, I don't think it's really healthy. I mean, for some people, if you increase access, if you increase availability, you increase disorder. You increase the number of people who get in trouble with it.
Right.
And there's no denying
it's all clear from sort of the people, the institutions, the think tanks that have looked at this, that it's safe to. The prevailing opinion around decriminalization is it does not increase the amount of the drug used. But a clear opinion also about legalization is you do increase the amount of the drug being used. So I would contend that right now it's good enough. We have decriminalization. There are like 3 people out of thousands of people in our jails who are there for marijuana offenses. It's really not driving up cost of the legal system. There's money coming in from decriminalization. And we're not ready for the impact of the increased use of marijuana. Our prevention efforts are obviously weak. I mean, the money's being taken away from them. Our prevention departments have yet to weigh in on this issue about marijuana use. And Vermont youth, 12 to 17 years old, have been leading the country in the last 2 national surveys on drug use and health out of the country. Our kids are using more marijuana than anybody else, and that sort of statistic is preceded by the idea of marijuana, medical marijuana, and liberal attitudes and misguided attitudes about it not being harmful.
Well, I just wonder, under this present administration, if the people involved with drug treatment and prevention, and I mean throughout the system, not just the state employees, but agencies and everybody else, if they're just a little nervous about speaking up on this issue. And the other thing is, I realize that some of them say, "Oh, I smoke pot, and it wasn't that bad," or whatever. And so people are just kind of. The people I thought would step up and sort of speak up and say, this is a bad idea. They haven't done that, and I'm not so sure. I mean, I don't know how they're going to feel about it. Do they really think it's a good idea that we have this drug, that we have people stoned? I mean, is it to make it legal? I just don't know about it. I mean, is it that strong of a community in Vermont that want to make this legal, or is it a very small minority who, because of they have some commitment to this and think it would be some great achievement if we did it?
Yeah, they're going with the flow, and I think somebody needs to stand up and say, what is really in the interest of people? What's in the interest of our health? And if you want to legalize, I think somebody should ask a pointed question such as, what are we going to do when we create more children who are using and becoming addicted as they grow older?
Well, I'd like to find one politician that was against the legalization so I could send them a check.
Right.
I mean, I'm serious. I mean, I know they got like lots of candidates are coming out, and I'm really concerned that this is going to be something that the next candidate, whoever gets elected governor, it will be too late. Yeah. And it'd be nice if we could stop it this year. But I have a feeling they've counted the votes in the legislature. Yeah. Everybody keeps talking like it's a done deal.
Well, the medical societies are getting ready to gear up to fight this and argue against this, so hopefully it won't be a done deal.
Yeah. All right. But I think it's a little Pollyannish when they think about doing it the Vermont way. I just don't see it.
Yeah.
Anyway.
We could talk about this a lot longer.
We'll have other things to say.
Okay.
Thank you.
Yeah. Good night.
Good night.